And I would request Dr. Shyamal Dwivedi to throw light on us as cataract surgeons from a retina surgeon's perspective as to what and how we should be dealing with such patients who already have existing retinopathy and macular edema and present with significant cataract.
So good afternoon, everyone. And thank you, Dr. Shail and everyone for allowing me to present on this podium. So these are my financial disclosures, and I'll be discussing on diabetic eye disease dealing with cataract and diabetic macular edema. So India is set to become a diabetic capital by the end of 2030, and prevalence of diabetic is 10.8% in rural population, and prevalence of diabetic retinopathy is 12.2 in rural population, which doubles in the urban population. So 98% of type 1 diabetics and 60% of type 2 diabetics will have some kind of diabetic retinopathy, and 53%, around more than 50% of type 1 will have a proliferative eye disease. So it is very important when you take a history of the patient to know whether the patient is simply a type 2 diabetic or a type 1 diabetic. So now we come to our main discussion, that is treating cataract and DME together. So there are two approaches for cataract and DME. The first approach being the conventional approach, in which we try to treat the diabetic macular edema first by giving appropriate intravitreal injections or lasers, and do a cataract surgery 2-3 months later once the macula is absolutely dry. And the other approach is the combined approach, in which we treat cataract and diabetic macular edema with appropriate intravitreal injections. So these are some candidates who are good candidates for combined approaches. They are patients with advanced cataract in which we are not able to see the retina. Those young diabetics with posterior subcapsular cataract having excessive glare and who would be facing difficulties in their day-to-day life with driving. And certain patients with comorbid conditions or disease in which they may not be able to come to the operation theater again and again. So according to the study conducted by the Journal of Cataract and Refractive Surgery, it has been said that nearly patients undergoing cataract surgery, diabetic patient undergoing cataract surgery worsens, diabetic macular edema is worsened in about 25 to 60% of the cases. So if we go with the cataract surgery of the patient, pre-operative evaluation is utmost important, and it goes without saying that counseling is one of the foremost part of this thing, and giving a proper chair time to the patient and talking to them and making them understanding their own disease is very, very much important. And of course, a good glycemic control, and there should not be any infection for any patients who are undergoing any cataract surgery. So again, this goes without saying that in-depth clinical examination or the evaluation is also very much necessary. I would emphasize on 2 points that a gonioscopy is a very important factor to rule out any surprises, where we can sometimes miss the neovascularization in the angles in diabetic patients, which may lead to dreaded outcomes later on. And the other thing to incorporate in diabetic patient is to do a pre-operative OCT to rule out any diabetic macular edema. So just to refresh our memories, diabetic macular edema is the accumulation of excess fluid in the extracellular space, and the picture looks as you see on the screen. So there are various diabetic management options ranging from anti-VEGF agents to laser photocoagulation and to surgery. So now we come to the real world scenarios. Our team was involved in a multi-centric trial which concluded that dexamethasone implant is a valid option for treating diabetic macular edema with cataract in treatment-naive eyes. So here is a gentleman who presented to us with an advanced cataract for his right eye and a big diabetic macular edema. He was subjected to cataract surgery with a dexamethasone implant, and at the end of 3 months, he's still maintaining a decent visual acuity at 6/12 with though some amount of spongy edema, but he's doing very well. The next patient presented with a massive DME and an advanced cataract, and he too underwent cataract surgery with diabetic macular edema, and he is also maintaining a very decent visual acuity. This patient is the breadwinner of the family, one-eyed, and he is the only sole driver of the family. So he is very, very happy after getting a dexamethasone implant, and he is still able to drive with little bit of difficulty. So this is how a combined approach is performed. Cataract extraction is first done, and once the cataract extraction is done, an IOL implantation in the bag is recommended, followed by a dexamethasone implant in the inferior temporal quadrant, and we need to make sure that the implant goes into the vitreous cavity, which is seen through the pupil. So he is a one-eyed gentleman. His right eye is almost a burnt-out retinopathy and a lot of tractional component, and he is hardly having any vision for the right eye. And the left eye is presenting with a diabetic macular edema and a cataract. We went ahead with the dexamethasone implant and the cataract surgery, and we were very happy to see that he regained his normal visual acuity, and the foveal contour was beautifully restored. So this patient further subjected to some focal and grid laser. The left one being the preoperative profile of the patient, preoperative fundus photo, and the right eye is after the focal laser, and we can see a beautiful resolution of the hard exudates, and to our surprise, the patient has not had a recurrence after this focal laser. So this is an interesting case. So the left picture is the preoperative picture of a gentleman who presented to us for a cataract surgery, and we did a preoperative evaluation, and we found everything to be normal. The only positive finding was his diabetic mellitus type 2 since 18 years. Except that, no other positive findings. And we went ahead and did a cataract surgery, and we were surprised to find that he developed macular edema for both of his eyes, right more than the left. And then we subjected the patient to fundus fluorescent angiography, and at that point of time, we realized that he does have some sort of diabetic component in his eyes, which was missed preoperatively. So we went once again with the dexamethasone implant, and the foveal contour is wonderfully restored with a normal visual acuity. So this gentleman is a gentleman with a chronic kidney disease, and he had undergone a pan-retinal photocoagulation years before, and he actually did not go to any follow-up after his pan-retinal photocoagulation. He was referred by his nephrologist for an opinion, and we could see that pointer. Okay, I got it. Fine, that's okay. Which is the third? Okay, so if you see, we can see a neovascularization over here in the right eye, as well as a neovascularization for the left eye. This is very well seen in the red-free photograph over here and right over here. So this patient was not a good candidate for dexamethasone implant, and thus we went ahead with an appropriate anti-VEGF injection. He also did have a DME, so we went ahead and treated his left eye first with the appropriate anti-VEGF. And after the anti-VEGF treatment, we can see for his left eye that the neovascularization has vanished totally. And we further topped up this patient with some aggressive PRP, and the patient is doing very well. So this was his left eye which we treated, and before we could treat his right eye, the right eye already landed up with a vitreous hemorrhage, which we are still following up, and if required, the patient may land up with a surgery for his right eye. So this left eye was done on time. So there is this is one more one-eyed patient who presented to us with a vitromacular traction, one-eyed and quite disabled patient who had some macular edema and a vitromacular traction. So this patient had to undergo a cataract surgery along with the vitreoretinal surgery. So first the cataract surgery was performed. The wound was sutured to make sure that the vitreoretinal surgery can be performed in a proper way, and 3 pars plana vitrectomy was started. So the vitreous is stained with the triamcinolone, and it is trimmed, and later on, once the vitreous is trimmed, we went ahead and injected the brilliant blue dye, and under the brilliant blue staining, we did an ILM peeling for the patient. So after the ILM peeling, the patient was topped up with some laser, and we were very happy to see this type of outcome with almost near normal foveal contour, and patient maintaining a beautiful visual acuity of about 612. So this is my last case, and this case is a VMT and diabetic macular edema along with the hard exudates. And this is the left eye, this is the right eye. So we went ahead and gave a dexamethasone implant to this patient, and the edema got settled, but we can see the plaque of hard exudate just beneath the fovea, which was the main factor reducing the vision of the patient. So we had to subject this patient further to a vitrectomy, cataract and vitrectomy, of course. And we are trying to remove the posterior hyaloid and the ERM above it. And later, the same way as I showed you in the previous case, we went ahead with the brilliant blue staining. We went ahead with the BBG staining and did an epiretinal peeling. Again, finally, we closed the case after doing some top-up laser. And we were very happy, as well as the patient was very happy to see the outcome, maintaining a beautiful visual acuity and total reduction of the hard exudates. So my take-home message is counseling is extremely important in the patient, because it is the patient's disease, and the patient needs to know what he is supposed to undergo, what care he needs to take, and we are helping him to reduce the burden of his own disease. So counseling is an extremely important part. The other one being the tailored approach, customized approach for each and every patient. So one shoe does not fit all. So it is something like that we need to take care, and very close follow-up and working with a retinal colleague is of utmost important. Thank you very much for your attention.
Thank you, Dr. SHYAMAL, for that excellent array of cases. I think plenty of take-home messages. The first important take-home message that I got was the so-called normal case that you showed, which flared up immediately post-cataract surgery, and that is something that all of us dread. And I think what you correctly showed was that although the OCT was normal pre-operatively, there must have been microaneurysms or few dot plot hemorrhages which were probably missed, which you nicely showed just 1 month post-operatively when you did the FFA, you saw the diabetic retinopathy leakage is already present. So don't take cataract surgery in diabetic patients lightly. Quite often with a relatively dense cataract, it may not be possible to see the retina very well. So take the help of your vitreoretinal colleague. The other thing what I also learned from your presentation was that now it seems that more and more vitreoretinal surgeons are preferring a dexamethasone implant, particularly when combining it with cataract surgery. And I see that quite logical as well, because the steroid component will also help to improve the cataract surgery outcome and has a longer duration of action. But I think your last case taught me a lot more, that if you find that the patient is one-eyed, or the retinal condition requires first stabilization before you can decide what form of further management this patient is likely to require, then don't be in a hurry to combine the surgery straight away. Just operate cataract with an injection. First, let the retinal surgeon take his time, treat him with whatever ways he wants to. Like in your case, you showed treating it with an injection. And once you found that things are stable, but he still requires a vitreoretinal surgery, so therefore the patient is also now more mentally prepared in the 1 to 3 months that he's undergoing retinal treatment, that he has two separate diseases, because then otherwise everything comes up that after the cataract surgery I required the retinal surgery. So I think these are some very, very important take-home messages that I would take back. And I think the most important is working in hand with your vitreoretinal colleague. Don't hesitate. You can never under refer to your colleague. You can do never.